Good morning, everyone. It's my pleasure to welcome Dr. No as our guest speaker this morning. He currently serves as co-director of biostatistics in the Division of General Medicine at the Beth Israel Deaconess Medical Center, and also as associate professor of medicine and biostatistics at Harvard Medical School and the Harvard Chan School of Public Health. He is well versed in biostatistics and statistics and was trained for his master's degree at the University of California in Berkeley, as well as for his PhD, and went on to do a fellowship in biostatistics at Harvard University. He has over 25 years of experience working as a statistician on numerous projects in diverse areas, including primary biostatistical co-investigator for several of Dr. Edward Marcantonio projects, including SAGE's Biomarker Discovery Project, the Multi-Omics of Delirium, and a project called READY, Researching Efficient Approaches to Delirium Identification. And he also serves as a biostatistical mentor, has been doing that for the past 6 years, and many other impressive projects that I won't go into, because I think I would make a fool of myself, but they seem very impressive. So I think we are very lucky to hear this talk this morning. So thank you for joining us this morning, and I'll pass it over to you.
Yes, thank you very much, Alicia, for that nice introduction. I would also like to thank your chair, Dr. Min Zhou, for giving me the opportunity to speak to you this morning. It's not a research talk, it's more like a talk on tools that I use daily to make my work easy. And also some of these things I train the residents here at Beth Israel. And so it's nothing about delirium or anything that I do in terms of the clinical research topic, but I hope that it is useful to you. So, and then I'm going to try to do a lot of these things interactively, meaning live session of the software demonstration, but I don't know how all that would work on Zoom. So we're going to try and see. If it doesn't, then I will go back to the slides and show you as much as I could. Okay. So let me share the screen and let me know if it looks okay to you. Can you see my screen?
Yes. Oh, yeah, I see the PowerPoint. Yep.
Yes, so the PowerPoint. So I have two screens. So the PowerPoint is sitting on the big screen. So I won't face you directly, but I'm going to just look at the screen of the PowerPoint here. And so here I have useful tools for data management and analysis and research. So this talk is going to be based upon three specific topics. I have nothing to declare in terms of disclosures. So these are the questions that your group asked me to look at, right? So I will look at are you still seeing my main screen?
Yep.
Yeah, so we're going to look at the concept of a database. What is it? And then I'm going to show you the difference between a real database and what we use often. We call it a flat database like Excel, and see how these tools are used in our data management of our research or clinical data. And then I will talk about the concept of a relational database. Some of you know what it is, some may not. My experience with the residents and people that I train is that they don't have a clear understanding of what that means. And almost all of the data that we see, that we use are in relational database. We're going to see what that means. And then you also asked to look at some tool for basic statistical analysis and statistical software that would be easy to use and would make your work more productive. So this is also an area that I'm interested in, that is the computational tools that would make our work easier. And the third topic that you asked me to speak on is the availability of large cancer and genomic databases. I haven't looked into or worked with a lot of large genomic databases. I work with proteomic data because of the fact that we have quite a few grants that are related to looking at proteomic data in relations to Alzheimer's disease, dementias, delirium, cardiovascular disease. So I'm more familiar with the proteomic data, but also I am a little bit familiar with some of the genomic databases out there. So I would just give you my perspective on that, okay? So what is a database? So often, there are two types of studies that we conduct. One is when we use the primary database, meaning we have to really come up with the data, right? So a lot of R01 grants that you work on, for example, would really require that component. That is, you have to go out, collect the data, and manage that data and answer one of the three aims that we usually have in an R01 grant. Or in a K award grant, for example, primary data collection is very important in training. So if you have a training grant, like a K award, you have to really know how to set up a database, work with it, and then do the analysis on that data. So the steps that I see usually a resident or fellow or a junior faculty member goes through, they write up the proposal, they get the IRB approval for the proposals, and then they do the grant submission, and then they get a NOGA, a new a notice of grant award, and then they proceed with constructing the case report form or finalize the case report form for the questionnaires that they use for their research. And it's a very important part of the research, that is, you know what questions to ask, how to formulate them, and how to lay them out in such a way that the questions are used in such a way that you could answer your three aims in your proposal, in your grant. And then the important thing here is then the data management, setting up of the data system that you can collect data for your research work. And then you start the patient enrollment process, right? So you go through the data collection step now, and then you manage that data, you track that data, and you report to the team. Like we have weekly updates of all of the grants, and the data component is so important. We track right from the very beginning the quality of the data, like the distribution of age, how does it look? Is it within a certain range? All of that is very key to the good analysis that you do at the very end of the data collection process. And then you do the analysis. When you have good data, you lock down the database, you do quality assurance of that data, and then you start the analysis, and then you work on the publications. So the publications of the analysis phase of that whole process, I would say, is probably just 20 to 30% of the entire grant. 70% of your effort, I would say, and resources would be devoted really to the data management of your research, of your grant. So the data are just so important. And without good data, you're really not going to get good analysis or publications out of it. And so in the primary database studies, these are the steps that I see happen very often. And that component of the database, the design of that database is so important, right? And then you have another type of study is a secondary database studies where you use the existing databases. And of course, you can see, for example, in cancer research, the surveillance epidemiology and end result program, the so-called SEER database, which is a massive population-based database. I'll talk a little bit about it, but it captures basically almost 36% of the US population in many states, right? You could actually get all of the cancer cases and look at the data at the population level, so that you really don't need to sample or do any kind of statistical analysis, really, because you have population data. So it's a very powerful database. Unfortunately, it doesn't contain the kind of genomic, molecular level type of data that people in pathology work with. But it has a subset of patients that you can work on. And we worked at these data and also the genomic data of the SEER database in our grants looking at the prediction of breast cancer. So that's an area that I have some experience collaborating with the breast cancer oncologists in using the SEER database for prediction of breast cancer diagnosis, breast cancer death. And then I work a lot with the Nurses Health Study, right? So the Nurses Health Study, is managed here locally by people at the Brigham. And it's a huge database that is used very often as well in cancer research. And so you have, that is a huge secondary database that a lot of resident fellows and faculty members use. The Cancer Genome Atlas, the PCGA, I'm sure you are familiar with, is also a huge database, a secondary database that is being used very often in cancer research, in genomic cancer research. It has roughly 11,000 tumors in there with different molecular platforms that you can look at, right? It has exome sequencing data. It has mRNA sequencing data. It has a subset of it, genome-wise data. Cancer characteristics are well described in a set of 10,000 tumors in this data set. So it's used very often. And I sort of read a little bit on the data structure at Tufts Medical Center. And I know that you use the EHR, which is the electronic health record system there at Tufts, which is a very good system. And you also have access or database, a secondary database that is a biorepository of the COVID-19 patients, for example. So a lot of these secondary databases can be used very well in grants, in RO3, for example, in grants, the grant mechanism that already, let's say that you already have the data to look at, right? So secondary databases are a study that you don't really need to worry about setting up a database and do what you have to do for the primary database studies. So as I said here, the only work that you have to do is to create the new analysis variables and be able to merge these data with the data that you work with. For example, the SEER database is often merged with CMS, Center for Medicare and Medicaid database. There you merge with the claim database so that you could look at utilization, you could look at cost, you look at a lot more robust analysis, not based just on using the cancer data, but also on, for example, looking at demographics, characteristics that may be helpful in predicting cancer diagnosis or the cost, different kind of sort of health research type questions, right? So when you're merging these national databases together, you have a very large system of secondary databases that you can do work on. So we do that often too in our work. We bring in the Medicare database, we merge that with large databases like the SEER databases to work with. So here, if I can move this. Here's an example of the type of primary databases that you have to deal with. So for example, we have this data, which is very often, this structure of the data that I see very often. You have demographics data, and then you have comorbidity data, which is like health history data that has ICD-10, ICD-9 diagnosis code, and all the things, but it's just a simplified version of what I see very often, a clinical database that people put together. And then you have the laboratory data, and you have the outcome data. And notice a lot of the data from health history, demographics, and laboratory come from the existing electronic health record system at the institution, right? It is the outcome data that you usually have to, a length of stay in this case, for example, is already there as well. Cardiovascular disease in this example is an outcome that you may have to follow the patient. So this is where you have to collect extra outcome out 6 months or a year into the follow-ups, into the follow-up duration. So here I give you an example of looking at just 4 tables of data. And the question is, if you have this type of data that you want to collect, how do you go about collecting this data and manage this data? So you can think of looking at this data by, for example, look at Excel file, right? So if you look at the Excel file, you try to bring the data into Excel, you set up the data like this. You look at demographics and you set up patient ID, age, and sex. And you can enter the data here in Excel like this, right? And then you can set up health history. And then you get the patient ID and the ICD-10 code, right? So these are sort of the newly created ICD-10 code for COVID-19 symptoms or outcomes. And then you have the laboratory data. I give an example of looking at 2 inflammatory biomarkers of C-reactive protein and interleukin-6 as an example. And then the outcome of interest. Here you have the ID, length of stay, and cardiovascular disease outcomes. So you can take up the data like this in Excel, right? And then you can manage the data like this. The problem with this is that there is no relationship between these data. And you can enter an ID that is incorrect, or an ID that is not part of the official patient ID. So if I put in P6 in here, Excel would allow me to enter that record. But the problem is that that patient doesn't exist. You don't have that data in demographics. And so the idea here is that there is no relation among these data sets that you have in this Excel system. You see, that relationship is very key. So if you don't have that relationship, and if you attempt to enter an incorrect ID into one of these tables, you can really screw up your data at the very end. That and the error mechanism on checking, for example, the range of age, for example, I could put in 800 here, and there is no protection of that kind of errors in Excel, for example. So error checking mechanism is very lacking in Excel. Now you can program all of that through Visual Basic, because Excel has a programming facility that you can do that, but it is really hard to implement these measures to make sure that you have very high quality data. So of course, we never allow our people to use Excel to manage the data. We call Excel a flat database and should not be used in managing data or tracking data or storing data. It should be used for just reporting or simple basic analysis. It could be used in secondary database study, because you can convert the existing data into a flat file database like Excel. So what you have to do is you have to bring in a tool that has relational characteristics, that had error checking mechanism that would protect the quality of your data. And so the tool that you have is a relational database is database like Microsoft Access, right? So so I go back to my slide here. You have to make sure that I still have the screen on, but when I switch between different software, I don't know if I'm still on. Okay, so again, you can see here, I lay out the 4 tables that we have for our data: demographics, health history, with the diagnosis code, laboratory data, and outcome data, right? So these things are not relational enough. You can make errors. I can put in lowercase m for male instead of the uppercase m. I can put in extra ID. I can create error like this, like an F in a field for CRP. So I'm mixing numeric and character data. And none of these things that I do, which could very often in entering the data, would prompt an error in the Excel system. So you have all these sort of problems that you may not expect to see until the very end when you start doing the analysis, right? So the problem again here is that you have the tables are not linked, potential error in the primary key, which is the ID, the patient ID. The fields and the variable lack built-in error mechanism. It lacks coding dictionary, meaning you never should put in character data if you could put in numeric data, because at the very end, when you do the analysis, it is really the numeric data that you need to do the analysis. So avoid at all costs using character data in your data, except when you have comments or things like that that you have to use. So the coding dictionary is something that you use. For example, you put in 1 for male or M for male. You should put 1 for male and 2 for female, for example, because 1 and 2 is numeric data instead of using F and M, for example. So that sort of coding dictionary is lacking in Excel, right? And Excel, I call it it's a database, but it's a flat database. It doesn't have that relational structure that you have in what we call a relational database. So a relational database capability is what you need for your data management. So what do we have in a relational database? So a relational database management system would allow you to link these sources of data, these tables of data at the design phase of the database. So you have to go through a design phase of the database. It has extensive built-in error checking mechanism at the record level and at the variable level. So you can build structure around, for example, A should be between 18 to 120, for example. Is a type of error that we see very often, right? Our range variable. And then use the coding dictionary to indicate numeric value for categorical variables such as race. So 1 for white, 2 for black, 3 for Asian, 4 for other races, for example, instead of typing that in or use character variables. So the coding dictionary is very important at the design phase. You have to make sure that it's well built. And the relational database, because of the fact that it is linked, all of the tables are linked, you can do very fast updating and retrieval of the data, right? So how would these data be managed better with a relational database? So here I will bring up, I don't think I have time to walk you through but if I have time at the end, I will try to start fresh and then show you how it is structured instead of and designed, right? So probably I'll see if I can do that at the very end. But how is it managed with a relational database? So here I show you, for example, in the example that I set up the table for the demographics table, right? So here in Access, so I'm gonna go live now and see if I could show you that quickly. So here in Access, right, I set up already these tables, demographics, health history, laboratory, and outcomes. So I set them up already like this. Now, but if you start fresh, then I can show you very quickly, right? You go into, now I use Microsoft Access, so we all have Microsoft Access, but of course, I will tell you something else that you should use instead of this, because Touch is what we use to the Red Hat database system that is well managed and centralized, and that is a system that we should use. I will speak a little bit more about it. But for example, this is a typical relational database, right? Microsoft Access that you should use for all your data management and don't use Excel. So the way you set it up is you start out with a blank database. So it immediately asks you, what do you want in this database? So if I put, for example, here, I will say test, I'm gonna call it just a test demographics table, right? The setup is very simple, it's not hard, but you can see here, it immediately gives you this format, and then I then create the ID variable for it, right? So I go to, here at the corner, you can see here, I can switch to the design phase, and then I call it demographics. And then here, I can put in the PID, which is the patient ID, right? And this has different types. So you can see immediately you are forced to structure your variable immediately, right? So here I would say that give me a PID that has, for example, 3 characters. And if you enter anything more than that, it's an error, for example. You can see right away that it gives you here the variable properties. So that means you have to define what that variable is. So if I say only 3 characters long, and then if you enter a lowercase p, it should switch to an uppercase p. This would then allow avoiding the error of lowercase versus uppercase. And then you can put in validation rule. You can put in validation text. For example, I can say that if you have an error, by putting 4 characters or more, I can say that only up to 3 characters is allowed. Right? So this kind of condition that you put on the definition of the variable makes it very tight, and the type of data that is allowed to be entered into the database. Right? So you can see here when you design the database, it makes you do that. And then I put in, for example, the next variable I want to collect is age. Right? So age is another variable that is a number, right? And I want to require that to have the data. So I put here under required that you have to put in the patient's age. I don't want to have missing data for age later when I do the analysis. You can require that. So if you don't enter age, you cannot be moved on to the next field. And then the validation rule here would be age has to be between, I say age has to be between 18 years of age and has to be less than 120. Right? So when you put that restriction in, immediately that range is used in the validation of the data. And then if you put anything all in that, the system will prompt and will say that only age between 18 and 20 allowed. Right, so you can see right away, so that age, and then you can put in sex as in our table. So if sex, I can then restrict sex to just a list of male and female, right? So I can put in here also short text, and then down here, the validation rule is that it's gonna just have male or female. So you put in F or M, and put in there, okay, so F or M, I'll show you what it looks like in the real table. And then the data are there, and now you can actually create a form for entering this data so that it looks nicer. So the default form, so save this here, and then in the real data that I have, let me show you what that is. So I go to the database that I have. You see, I have the data, and then the full system here has, for example, sex and age and ID. And then when you switch over to the data, if I attempt to enter, and I can look at the form for demographics. So you can actually create a data entry form. And if I attempt to enter any age that is outside of that range, it will prompt immediately an error and force me not to move on until I correct that error. So you enter an age value that is our allowable range between 18 and 20, for example. So it makes you go back, fix it, and then down here, for example, you only have an option of male or female. This type of constraint allows you to have better data, right? So you can create the database and the form that corresponds to that database. You can also create queries and all the things in the database system. And another thing that is unique also here is you can actually look at the relationship among these data. So if you look at the relationship among these forms, right? So if you if you go here and you create the relationship, you can see there is already among these forms, demographics, health history, laboratory, and outcome. I created a relationship that is, I allow the patients in the demographic database table to have many diagnoses of health history, to have many outcome, and to have many laboratory levels. So it's called a one-to-many relationship. And this relationship allows me to control for not having a patient with health history, but not demographics, for example. This would allow me to prevent you from entering a patient with outcome, but not with demographics, for example. So this type of errors would then be prevented. So this kind of relationship is very important in the relational database. So if you go back here in the slides that I have, you will see that I have the data, and then for each of the field here, I defined what it is, right? So for sex, it's F or M, and for age, it would be between 18 and 120, for example. So this kind of restriction, right? For each of these fields, you can see I put the characteristics of all of the variables set up on the right-hand side here so that you can see. And then the key design would be by that relationship among these tables, right? So let me move on here and show you, again, I show you that structure where the relationship is defined. And then you can see the form could also be designed for each of these tables so that it has a customized data entry form that you have reflecting the case report form, the real questionnaire. Okay? So for each of these tables, you can set up the so-called form for each of the tables. And then I have this slide here that demonstrates to you the kind of errors that we would prompt you. For example, attempting to enter age of 17, where the range is between 18 and 20. For demographics here, for example, you attempt to put in another ID that has the same ID already in the system. So it would say that you're trying to create a duplicate ID so that patient should not be entered twice in the key database, right? The demographics. And then the laboratory data here, you enter a wrong date outside of the allowable range of date, for example, it prompts you an error. Here you could see that I enter an ID P6 that is not part of the set of allowed IDs from the demographic table, and it prompts me an error. So this sort of restriction is good. Now, what do you have there at Tufts? So at Tufts, you have this eClinicalWorks, which is a large electronic health record system that has really all of the data there at the medical center. You also have what we have here at Beth Israel, which is the REDCap system that is used for research. And it is really a wonderful system that I highly recommend that you use for all your work in the Department of Pathology. And if you click on this link, I think this link I have here should take you to the Tufts Clinical and Translational Science Research Science Institute, where they lay out everything that they do there. And I encourage you to look into it because the REDCap system is used worldwide, and we use it extensively at Beth Israel for research. And so you should make use of this existing resource at Tufts, right? And it's very easy to use, and the setup is very secure, and you can access it or allow access of all the team members, and it is free to you, and it has great support. I highly recommend that you make use of that, and that has all the features that I just went through very quickly with you with the Microsoft Access. It has relational database characteristics that is very standard and very secure to use. So you should make use of the REDCap database that you have there, right? The electronic health system electronic medical record system that you have there is one of the top 3 most popular electronic health record system. The EPIC system has a large market share, almost 30% there. But eClinicalWorks is also very popular, and it's locally. I think it's somewhere here in Whatcom, the headquarters. So again, the Tufts REDCap system actually has data that you can use because you are a member of the faculty or residents or fellows can use it too. But you have like 1 million patients' data there with lab values, procedure, diagnosis codes, medication, visit notes. All of these are highly precious data for research or for writing grant proposals. You do have a tumor registry. I'm pretty sure that probably come from pathology, but I don't know what type of data they have there. But the data are there, so you should look into it because it's all captured in the Tufts electronic health record system. But the REDCap system is highly recommended. You also are a member of the TriNet-X, which is a huge consortium of secondary databases contributed by the top pharmaceutical companies, as well as 170 health organizations in 30 different countries. So if you go to this website here, you will see that you are allowed to apply and use some of these data in this vast database network of TriNetX. It's a very popular system that I think you will appreciate the immense access and high quality data for your research work. And your 1 million patients' data are part of that system. So Tufts contributed that much data to this network, TriNetX, and they manage that data and allow you to retrieve the data in analyzable format. So you really should look into it. You're also a member of this N3C, which is the National COVID Cohort Collaborator, that has nearly 4 million persons with almost 1 million positive COVID-19 cases. You are allowed to apply and access these data for research. I think we are a member, Israel is also a member of it. And the Tufts Medical REDCap, you can see here that it allows you to get the data, de-identified data set that is free, right? And if you are a member of Tufts Medical Center, you have access to it. We outside, if we want to get to it, we have to apply for permission of from the IRB. But you have it, and I think REDCap should be used. So here I show you a map of the REDCap system that is being used nearly with 5,000 active partners in 141 countries. It has been used to generate almost more than 1 million projects from 1.6 million users and used extensively in research and publications. Here I show you the REDCap system that I have, that I use often too here at Beth Israel. So I click on this link, I think it should take me to the Beth Israel REDCap system, right? So immediately I have access to it. I think you can get into it, and then it will allow you it showed me immediately live that I have access to 3 databases from our team. We set up these databases, and you can see that it's very fast, and I can access that data. I can also, here look at the data live immediately, very quickly, and export all of these data into analyzable. For example, if I want to look at demographics of this particular clinical trial that we did for this particular patient, I can do that. I can also look at the exporting of this data, and the exporting of these REDCap data is very efficient. It gets your data into SAS or some analysis software immediately. And so the REDCap system, as you can see here, is powerful and safe and should be used by your group. Let me go on here and say, so we use REDCap for all of our research projects. And then via what we call application programming interface, the API, we could link to mobile apps and institutional electronic health record system. So the step that I see usually would take here is that we, so again, the REDCap system that you have is linked to eClinicalWorks, your EHR. It could be also naturally linked to Epic, because Epic is built in such a way that you can link different systems to it. So if you have Epic in-house, you can also do that. But eClinicalWorks, the electronic health record system that you have, could naturally be linked to REDCap as well. So what I see very often here is that in our group, these are the steps that we take, right? So we write up the research proposal, we get IRB approval. If we get funded, then we go on and finalize the annotated questionnaire. So this step is very important because it has to do with the design of the REDCap database later on. And then we designate a key database manager for the REDCap project of the grant. And that person can assign access to different team members. And you have different level of access authorization as well. And then you design and code the database, the reports, do the data collection, export the data to the SAS statistical analysis system for analysis or other systems, and then publication, right? So these are the steps that we take in every grant that we work with. And you can see the REDCap system played a big role. Here's an example of an annotated form we designed prior to building the study REDCap database. So we have the questionnaire design. We go in and then we code it, we give it variable names, and then we use numeric coding for everything. So instead of no or yes, we use 0 and 1, for example. So the data would contain only numeric data ready for analysis. Right? So we then, so this is the work that we did in a major publication in the Annals of Internal Medicine, where we did the derivation and validation of a tool that we call 3-minute diagnostic interview for CAM-related delirium. As you know, delirium is a very important condition that is really under-detected, and we study it very extensively. Our group is quite specialized in looking at delirium, dementias, and Alzheimer's diseases. Here's another work that we did where we actually do the data collection using a mobile app in the iPad machine, and then we link it to, we get the data uploaded to the REDCap system, and the REDCap system is built to link to the mobile app, and then from there it's linked to an analysis system in SAS that we then get the data out and do the analysis. So we recently wrote up and released the actual code that we developed in a new publication. We call it a mobile app for delirium screening. That just a couple of days we get this in print in the Journal of the Medical Informatics Association. So this is a system where we use now data collection. We eliminate paper entirely, and we use mobile tools like Android or iPad to then collect the data at the patient bedside. That data is linked directly to our EHR or the REDCap research, REDCap's database, and then export it for analysis. So that system is what we want to use, and it has worked quite efficiently so far for some of the projects that we're making use of. So here for my advice at the very end of this section on data management is that do use REDCap for the department for research projects as much as possible. Designate some key staff and have them receive training at Tufts Clinical and Translational Science Institute, the CTSI, and consider drafting SOPs for how a study database should be set up, and in general, how to deal with data management issues in the department. Design the study case report forms carefully and use coding dictionary to make sure that numeric values are used for all of the data as possible. And use a common patient ID throughout all of the projects. For example, designate MRN to be your primary key ID so that data can be linked among them, among the REDCap databases, and can be linked to the Tufts Medical Center electronic health record system. And that is very important if you want to then retrieve data that are already in existence, demographics, comorbidity data, laboratory data that are already in your EHR system. Your ID is very important. So be that the MRN or some special ID that you devise, that's like social security number shouldn't be used, but they use it to link the data, right, as well. So, but the MRN, I think, is something that we use to link our research data with the institution electronic health record system. And then establish within the group an informal quality control group of rotating staff to ensure the department's REDCap research data are well maintained and supported. Right? Encourage active use of the department's data and Tufts EHR data for lectures and research proposals. So this is what we're trying to do here at Baptistville as well. Just to know what your institution is collecting the data and how accessible that data is crucial. And we do that very often. We tap into the system, download the data, and look at the hospital data because millions of observations in there that you can make use of, right? And that allows you to also understand much better about your patients. And therefore you could, hopefully give them better care through research. Now, this section is on statistical analysis. So I have maybe 10, 15 minutes left. So the tools for basic statistical research, again, I will give you my perspective, right? So how do I look at these issues in terms of statistical analysis? And that is, you have to have very clear research questions of the question that you want to ask that have clinical implications and how the data could be used to answer those questions. So formulate the research questions for the proposal or the paper is so key. I always ask for just one page of the aims, and I look heavily at the research questions first just to make sure if they make sense and they are understandable. And it's a lot harder than you think, right? Formulating good research questions. And then the study design is very important. Is that a RCT? Is that a randomized controlled trial? Is that a retrospective case control study that you're using the existing data? Or is it data that you're collecting and follow the patients in a prospective cohort design or a prospective case cohort design? So all of these designs are extremely important at the initial phase of your research, right? Or your And then you have to proceed to then look at sample size analysis. How much resources you can devote to collecting the data. That depends upon how good your power analysis is. You don't want to under-allocate or over-allocate your resource by collecting too few patients and therefore lack the statistical power to answer your hypothesis, or collect way too many patients and don't need that many patients in order to answer your question. So the power analysis is very key in the design phase of your study. And then you do the database management, right, data setup, and then you perform the analysis. And in the analysis, I see basically two levels of analysis. One is that when you have a randomized control trial, you have to then check to make sure the randomization is good. If it is good, then the statistic is very simple, right? The beauty of the randomized control trial is that all your measured confounders or unmeasured confounders are taken care of by the design. So you really don't need to do any fancy statistical model. You basically use very simple statistics, what we call univariable statistic, like chi-square test, a t-test, to answer the final question of whether the drug is efficacious or not. Right? So in RCT, the analysis is very simple. It's very simple because of the fact that you have that nice design of randomization in the study. So confounding is taken care of by the design of the study. Now, therefore, you just have to look at the data descriptively and do very simple statistics. For observational study, it's much tougher. Multivariable modeling would have to be used, right? So you have to use multiple regression, multiple logistic or Cox regressional model. Advanced statistical analysis is used to then, what do? Take care of confounding issues, right? Tease out the effect due to confounding and focus on the adjusted effect of the measure of interest. In this case, for example, intervention or drug or some measures of interest that you're looking at. And modeling that and be able to separate out the effect due to confounders and the effect due to the real exposure of interest is really difficult. So in observational study, we put so much effort into the modeling of the data because we use modeling to basically compensate for the lack of design and therefore issue of confounding in our data. And then we have to do model diagnostic through discrimination and calibration of the model. And so it's a lot of work that goes into the analysis of observational studies, right? So what statistical software is available to you there at Tufts? The Excel has the analysis capability, but it's very rudimentary. You do have access to SAS, which I consider the gold standard software for data analysis, right? If you submit a COVID-19 vaccine trial to the FDA, I bet you that it is in SAS. Right? So SAS has high quality assurance in their software, and it is used in industry, in finance, and in academia widely. So we use SAS software to do all of our work because of the fact that it has very good quality assurance, and what you have in the output and the result is highly reliable. Tufts also has Stata, SPSS, R, and NVivo, and all of these software are free to you. NVivo is a software that is used if you have qualitative studies, right? If qualitative studies, then you can use NVivo software, and these are used also for qualitative and quantitative data. But you can go to this website here and have access to the service and the free software that Tufts offers. We don't get here free; we have to pay some money, but I look into it, and you do have free access. Again, JMP also is an easy to use product, equivalent to Excel. It's also controlled by the SAS Institute. So the JMP software is a powerful version of the SAS software, but it is for users who do not like to write code. So we also use JMP for our fellows, junior faculty members who don't have support of an analyst. So we allow them to also use JMP, but JMP and SAS are really expensive software. However, at Tufts, you do have SAS, you don't have JMP, right? So I recommend it if you don't want to write code. JMP is a software that I highly recommend because it's produced by SAS Institute. So you can think of it as a SAS software for analysis, but with user-friendly interface. Another software we use to train the residents here in the design of the study is, we call it PS, which is managed by Vanderbilt University. And it is also free that you can download from this website. Here is a quick list of things that you can do with the Excel software. And you can see I have JMP embedded within Excel. And if you have JMP, it will automatically link to Excel. And this is a powerful SAS equivalent advanced analysis software. This list over here is for Excel. And you can do a lot, but you can see that if you have binary data, like having yes or no COVID, and you want to see whether inflammatory biomarkers are related to the likelihood of having COVID-19 diagnosis, positive diagnosis, you can use all the tools, but not Excel, because Excel doesn't deal with binary outcome. Logistic regression, for example, cannot be done with Excel. So it's quite limited. You can do descriptive analysis well, but not more than that. So I highly recommend that you look at JMP as a potential software for your group, perhaps a couple $100 a year. But Tufts, if you go to the Tufts software group, they might be able to get it for a very good price as well. But I highly recommend it because it's a very good software. I actually have a demo here for you if we have time to look at it. But here, for example, an example of an RCT and the type of analysis used, right? So if you look at COVID-19 trials so far, so on the left here, this was published a couple of weeks ago by the New York Times, and Dan Baruch is the virologist in our group here at Beth Israel, who basically invented the Johnson & Johnson vaccine. And you can see here the reported efficacy for each of the drugs, right? Here you have Moderna in the range of 90-some%, above 95%, and Pfizer also in the range of 95%. And you have lower for Johnson & Johnson later on because of the widespread variants. So all of the drugs down here were done in the presence of the variants, whereas here without the presence of the variants. So you can see the cluster of very high efficacy rate for these drugs. Now the analysis of this is very simple because it's a randomized controlled trial. So all you need to do is compute, in this case, they reported this efficacy rate, right? So they look at the relative difference between people with COVID diagnosis, in this case, 1.27% in those who receive the vaccine, the Johnson & Johnson vaccine, and here 0.36% of COVID positivity in those who receive the placebo. So you calculate the relative difference of those with the vaccine, those with the placebo, and you get 72%, and that is the vaccine efficacy. Very simple analysis because of the RCT, everything else is confounded for. So this number is can be interpreted as a causal effect of the vaccine on COVID positivity, right? So that is a reduction of nearly 72% for the vaccine group relative to the placebo group. Very simple, two fractions and a relative difference give you the result of the trial. And this analysis is simple because of the fact that all of the measured and unmeasured confounders are accounted for in the design of the study. Now, whereas we did very much, if you look at this, so here I give you a paper that we just published, and we look at 1,300 proteins in relation to the development of cardiovascular disease. And you can see that we have an observational study, and you can see here I outline basically the analysis steps to get to the final answer. Is very complicated and just very difficult, right? So to establish the association between proteomic expression and CVD incidence, we have to do many steps, and most of it is modeling. Right? So we use univariable modeling, multivariable modeling, model selection to basically get at the actual effect of protein on cardiovascular disease, and it's really difficult to do. But this is sort of a standard analysis that we do. I think it's very similar analysis too that if you look at genomic data, it's a very similar path, similar type of analysis that we do with observational study, and it's quite complex, right? So and here I show you the software very quickly. We use to do the power analysis of the trial. I apologize, I don't have a lot of time to go into it, but at the analysis phase, is complicated for observational studies. We train our resident, and we spend like, each of the residents here at Beth Israel is given up to 9 weeks to do research. And we have 3 weeks where we train them with methodology. And I give a lecture on power analysis, and then I meet with the group for the whole day to look at their studies and look at the design, look at the issues of power analysis. Just to use this software, it takes a whole day to train them and to get them to come up with the right number of patients that they need for their research projects. And so this is, for example, we're looking at the number of patients that we need in order to look at the effect of a particular protein, that if you elevate or have upregulated elevation of that protein from below the median to above the median, you would increase the likelihood of CVD from 10% to 33% in this population. And how many patients do you need to study that, right? So that's really important because it's expensive to do assay on proteomic data. It costs like $750 to do a SomaLogic scan and get 1,300 proteins from these patients. And so 1 or 2 patients could make a difference, right? So determining the sample size is very important, and that is a big component of the study design. I probably won't be able to touch on all of this, but I just want to show you, we perform the type of analysis that would allow us to get to the pathway analysis of how these proteins would affect CVD. And we describe that in our paper. But what we say is this type of analysis is typical of the proteomics of genomic study. And if you can see, all of this work is done using the SAS software. And then I repeated all of this using the JUMP software that I unfortunately don't have time to demo it to you. But you can see this is all repeated without coding, without any kind of technical coding of the analysis. And it has basically the same results. So in terms of analysis, I think I recommend JUMP to be brought into your research group. And then, I'd be happy to have with the initial training, if you would like. I give 1 or 2 workshops and people can get a hang of it and look at the analysis. So if you have like a journal club, some kind of training, I'll be happy to come over and spend a few hours with the residents, as I do here at Beth Israel, and help them with the sort of, laying the foundation for the analysis of the data. The third section is really important, but I don't think I have time to go into it. What I'll do is I'll hand out the slides, and then the group could certainly look at it, or let me know if there are questions. But I look into the large genomic databases, and you can see here I focus more on the GDC group that handles the Cancer Genome Atlas. So you can see the beauty of this is that in the 10,000 tumor or 11,000 tumors that they look at across those different cancer types, it has so many different molecular platforms like gene expression, protein expression, mRNA, DNA methylation, copy number variation, somatic mutation, also demographics and clinical data. It's a really rich data set. And now I know that it has decent online analysis tool that I did try, and I also download some of the data and look at it. But you can see that now it has more data in there because it has the contribution from companies like Foundation Medicine. It has also contribution from Count Me In, a very popular database where people, individual can contribute data. And now this database now, TCGA now, with additional data, goes up to nearly 85,000 cases of data in there with almost 3.5 million mutations of 23,000 different genes. So this, if you go into this website, you will learn a lot, and it's really impressive genomic cancer database. I also look at this Kaplan-Meier plotter. This is linking the genomic data to survival or to outcomes in terms of survival. So I find it to be very interesting because patients do want to know that, right? So if they have a mutation, they want to know what is my chance of survival, 5-year or 10-year survival. So you can look at this as a tool to have some idea as to what the epidemiology of that particular mutation would be. Now you can do the same thing too with this GDC website. You can do that as well because of the fact that they also look at mutations in genes characteristics in relation to survival. Of course, you know about this, the COSMIC database, right, with the largest database of mutations, somatic mutations, and it has now very well built, but it also captures data from TCGA and the International Cancer Genomic Group. So this is also another good one. Now, the one that we use a lot is the SEER database. So in the SEER database, you can see that it has 16 million cases covering nearly 40% of the population, has demographic medical history, has tumor morphology, but not molecular data, right? So you can look at a lot of tumor characteristics like staging and other things that would allow you to, in relation to the outcome. And it also has linkage to the Medicare data and all the CMS databases. Very sophisticated tools and now really easy to use. So I recommend if you do look at cancer projects or proposals, you really have to look at the SEER database. I also have a list of these databases from this really helpful paper, which is only about 2 years old, has an updated list of all the genomic databases that you can go through. And then I show you here some of the work that we've been using, the SEER database and others, like the Nurses Health Study, the Women Health Initiative, to do prediction. We have a big grant from the National Cancer Institute to look at prediction of breast cancer using different methods of analysis by adjusting for competing risks in the elderly patients, because in these patients, even though they are diagnosed with breast cancer, they're likely to die of cardiovascular diseases or some other competing events. And so we look at this, and we look at also the contribution of genomic data from a subset of these patients to see how well the prediction could, how much better the prediction could be. So far it gains very little by adding genomic data into it. But all the groups, like this group that I highlight down here, would say that they would add 7 more points to the area under the curve to the prediction model of breast cancer by adding in the genome-wide associations, genes. So we are looking into it in a subset of patients. The final slide is that in our work, we're looking at prediction of cancer outcome. And these areas, and we focus on the increasing the C-statistics or the area of the curve, right? And the closer to one, the better the model of prediction. So far, the technology is that the model is at about 0.67, 0.69, but it's quite low. But you know that it's used, the GAL model for breast cancer prediction is used in clinical setting, advising patients. A patient will be interested in, they ask questions like, how often should I have a screening and I'm over the age of 80? How likely is that I will die of breast cancer or some other causes? And so the model, the prediction model of breast cancer is very important. And we are exploring different areas. For example, we believe that therapy, patient characteristics, omics data like genomic data or proteomic data, diagnostic screening technology, the support of our government, right, in terms of education and medication and treatment, as well as a physician skill experience. It's hard to collect this data. We believe all of these domains contribute to the prediction of breast cancer. And we are looking into all of that, also with the proteomic and genomic data. I also work with other groups when we look at liver cancer diagnostics and prediction as well. We use the same type of modeling exercise to address some of these issues. If you are interested in international work, you should also look at the Institute for Health Metric and Evaluation database. I haven't updated this, but it has a huge number of collaborators and data. For example, I used to look at data from Vietnam in relation to the United States. So they have some good data on cancer. I don't know if much is in the genomic data, but some are there. So that's on another database to look at as well. Sorry, I'm rushing through to cover a lot of these things, but I hope all of this is a bit useful to you, especially in terms of the data management and analysis tool that you may like to use. I'll stop there because I think I'm over the time limit. Be happy to answer 1 or 2 questions or however that you have. Okay, thank you very much. Okay.
Thank you very much. That was great.
Yeah, I'll be happy to send the slides to you if you like to send it to the group.
Yeah. I wanted to say, I wanted to add about REDCap that it's great in the fact that multiple different people can use it online, and you can like download. I think you can like share your project. Is that right? With like
Yes.
different users.
Yes, you can assign access privilege to different group of users that you like. So you can allow people to have access to only a portion of the data, some of the a subset of data. You can do that in Red Hat. It's truly powerful. But you do have the data management people there at the institution that could help you address some of these issues in terms of access and control of your data.
Great, yeah. Yeah, I didn't realize we had all of those tools, so it was very useful.
Definitely, yeah.
Thank you very much.
Thank
Sure,
you
sure.
so much. Yeah, thank you. And we would love the slides if you're willing to share them.
Absolutely. I can send that to Alyssa, right? And she can distribute.
Yeah, sure. That'd be great. And then I can just
Perfect.
distribute to everyone.
Thank
Yeah, I apologize if I was flying through so quickly to help.
No, not at all. That was very
Okay.
good.
No.
Okay. Have a good one.
All right, very good. Thank you.
Thank
Bye-bye.
you very much.
Okay.
Bye.